Okay, we're gonna return, and again, my name is Jason Beste, and Alexa and I are going to speak to you about some ethical considerations of global health work. And there's some similarities with what Eliza talked about, but we're going to talk also more about kind of pitfalls, what we've seen done in global health work, and kind of ways we can try to avoid those pitfalls when we do global health work. What I would like to do is just pass it off to Dr. Alexa Lindley to give a short introduction.
Hi, everyone. Like Jason said, I'm Alexa Lindley. I'm really happy to be here with you all. Thanks for having me. I am a faculty member in the Department of Family Medicine, and I came here after doing a global health fellowship through UCSF called the HEAL Initiative, which is a global health equity focused fellowship. And I currently am mostly engaged in global health education work in the family medicine residency and in our global health fellowship. And so I'm really excited to talk with you all. Thanks for having me.
Great. And we just wanted to let you know that we don't have any disclosures or conflicts of interest.
And I was just going to start by saying global health is a broad term that means a lot of different things that can be defined in a lot of different ways. This is one definition that kind of encapsulates what Jason and I are meaning when we're talking about global health. So a collaborative transnational action for promoting health for all. This is adopted from a definition from a paper called What is Global Health by Began, Hole, and Bonita. But there are a lot of different ways to define this. And we also just want to recognize that both Jason and I are clinicians primarily, but obviously global health work is much broader than just pure clinical work and includes public health work and policy and a lot of other things. But we'll be thinking mostly about this from a clinical lens, since that's what our experience is mostly. But also we'll be thinking about global health programs that incorporate more than just clinical care when we think about ethical considerations of global health work. And we also just want to acknowledge that we'll be talking about ethical considerations, but neither one of us is an ethicist. So we'll kind of touch briefly on some principles of ethical principles that I think Eliza kind of mentioned in your talk before. I didn't catch it all, so sorry about that. But we won't be really diving deep into ethical principles and ethics. Mostly we'll be talking about kind of how to make sure our work is following ethical principles that we should be thinking about.
Great. So here's the little bit of overlap from what Eliza was talking about. And she also mentioned I was going to talk about these 4 ethical principles briefly. You've had some really nice case studies on these already, so I'll go over these quickly. The first ethical principle, as we talked about, is autonomy, right? Which means individuals and also providers, as Eliza was mentioning, are free to make their own decisions with free and informed consent of all parties. Now, I'd like to share with you a couple real life examples of each of these principles as well. A real life example of autonomy I've encountered in the global health setting is actually taking care of babies who are admitted for sepsis, but instead of giving antibiotics right away, which is what we're trained to do here in the United States, sometimes we have to wait for all of the family members' input and consent before giving antibiotics, which can actually take hours. The second ethical principle is beneficence, which means, again, there should be a net benefit from the program or the study or the treatment being given. An example of this is starting empiric TB treatment on a suspected but not confirmed TB case. The benefits of starting TB treatment definitely outweigh those risks, especially when you're working in a high burden TB area and you don't have good diagnostics to actually treat TB, but you think from the clinical history and they're presenting symptoms that they probably have TB. Next is non-maleficence. So this principle, again, means that the actions we take must minimize the harm for others, and those who are influenced by the actions must have a full understanding of the potential risks of the action. So an example I've seen of this in the global health setting is actually being asked to do a procedure you're not comfortable or qualified to do. So don't do it, as we talked about in the previous case with the amputation. You should not do something that you're not certified or comfortable to do in a global health setting. And I've been in that situation quite a few times where people have had TB pericarditis with a huge pericardial effusion, and we're going into tamponade, and the question is I was asked multiple times, will you put a needle and do a pericardial centesis? I said, I've never done one before. So I've worked along with my colleagues to figure out what would be the next best option, and et cetera. But but you don't need to do things that you're not trained to do, and you shouldn't do that. Lastly, justice is the ethical principle that stresses individuals should be treated fairly all of the time, and that resources should be distributed equitably. Now, we know that a great real life current example of this is the COVID vaccinations in resource limited settings. Many countries don't have access to the COVID vaccine, nor do they even have the support or the distribution abilities to actually roll out a COVID vaccine. So this is a major ethical problem that we're facing.
And we also just want to acknowledge that there is an inherent ethical dilemma in any global health work we do. So there are severe disparities that exist between those of us living in the wealthiest countries in the world and those living in the lowest income countries in the world, which creates a moral responsibility to do global health work and assist these communities, but also many ethical hazards of doing that work. So that's kind of what we're going to dive into a little bit more. Next slides.
Now, we're gonna share just one case study with you, highlighting some of these ethical principles that we just discussed. So this is a case that actually came from a United States trained OBGYN physician who practices global health, and she wrote this case in the BMJ Global Health blog. While visiting Uganda with a surgical team, a Ugandan resident asked me to help with an ultrasound of a pregnant mother. While performing the ultrasound, we noticed that the fetal heart rate was severely low. Although I was quite concerned, the Ugandan resident did not seem worried. He asked, what would we normally do in this situation? And I responded that I would have already rushed the patient back to the operating room and delivered the baby via C-section and started resuscitation efforts. He considered this silently, and she was taken back for a C-section.
And then the case continues on. The cesarean section was performed and went well. A small, crying, healthy appearing baby was delivered and attended to by the same anesthetist for the cesarean. She shook her head. I was confused. The anesthetist stated that the baby wouldn't survive and there was nothing we could do once the baby started having difficulty breathing, as there was no neonatologist, lack of medications, and no respirator. The baby did die from respiratory distress overnight. So we want to take this case and just ask you all whether you want to unmute and call it out or put it in the chat. Are there specific ethical issues that this case brings up for you? And it could be one of the ethical principles we mentioned already, or it could just be another observation about this case and an ethical consideration that it brings up for you. And again, feel free to just put it in the chat or unmute and call it out.
Well, Alex, I think people might be worn out of cases.
Fair enough. I see a couple of chats with these.
Here we go. Here comes some stuff. Okay. Unfortunately, harm done to mother with unnecessary surgery that could have prevented her life at risk. Yeah, thinking a few steps ahead in care, given resource constraints, consequences that we don't normally have to consider. It's good. And Priyanka said, performing a procedure intended to save the life of a baby, but without all the requisite components of the intervention. Yeah, that's great. Sarah, thanks. She says, I think the risk benefit to C-section in this scenario is very different given the lack of neonatal care available. I think it violated non-maleficence, unfortunately.
Yeah, this is Annie. I was just thinking about, in terms of autonomy, was the patient involved in this decision? And then also, did the resident feel as if they, I don't know if it's exactly autonomy, but could actually push back against this recommendation, given what he or she might have known about the system? Yeah.
Yeah, great. So I think you're all pointing out some of the important, issues that this brings up for us as well. So there are some power dynamics that you're commenting on, Annie, that may be hard to overcome for that resident. There was not a consideration of the poor outcomes, the maleficence that could come from this. There were maybe lack of considerations of the differences in the context where the provider normally is a clinician and is currently a clinician, and what the standard of care is in both of these places based on the resources available. So yeah, thanks all for those thoughts. And I'll just read the reflection that this author wrote about the case. So they wrote, I recommended a cesarean section for this patient with good intentions based on my training in the US. Although I did not force the procedure, I also did not recognize how being a white American physician could make my Ugandan colleagues doubt their training. Furthermore, my lack of training in context-specific medical knowledge made me unaware that viability, meaning the age at which the baby would survive, would be defined differently in various contexts. All of my privileges that structurally oppressed the patients I was treating in Uganda allowed me to influence a decision by the more knowledgeable Ugandan providers to proceed with a painful experience or painful procedure that cost this woman an unnecessary surgery and a painful recovery after a sorrowful event. So this case really points out that even if we have strong clinical skills and the best of intentions to help, we can still cause unintended harm. And we really want to think about ways that we could prevent harms in our work by considering the ethical impacts of the work we're doing.
All right, so now we're kind of done talking about those ethical principles, because I think you now know them really well after the past hour and a half. And we're going to move on to what I think is really kind of interesting, and will provide some good thoughts and discussions, and is about common pitfalls that we've seen either performed in global health settings, or what we've even done and what I've done in global health settings as well. And then what we like to do is share with you some of these pitfalls that we've witnessed or have done, and share with you some key principles that we can use to prevent these pitfalls from happening. Now, these principles come from published literature on proposed guidelines for ethical participation in short-term experiences in global health, but we also think that this can apply to long-term collaborations as we build partnerships abroad.
Great. So the first pitfall we're going to discuss is work that is self-serving, meaning that it provides value for the visitor without meeting the local community's needs. And I will just be honest and acknowledge that global health work always serves the individual participating, right? So in my work in international settings, I've gained new experiences, I've gotten to experience new cultures, new places, right? And that benefits me, even if my intentions are good and my reasons for doing the work are honorable. But really the ethical problem arises when global health practitioners are motivated primarily by a desire to gain skills or produce work for themselves, instead of being motivated by the goal of improving the health for the local community. So an example of this is similar to what Jason was bringing up earlier about procedures. So a provider who really wants to gain a particular procedural skill, traveling from their home country to a low-income country where they can get practice performing the skill that they're not trained to do in their home country would be an example. And some ways to avoid this pitfall are, number one, participating in collaborative programs that are really embedded within the local health system and not outside of them, and that are guided by needs that are identified from that community, as opposed to being guided by needs or priorities set by outsiders. And then a second way to prevent this pitfall is to provide services within our own scope and ability and training.
The next pitfall we see rather frequently are healthcare providers having inadequate understanding of the local context. So visiting healthcare providers often lack appropriate language skills, understanding the local cultures, medical training, and even accountability. An example of this pitfall that I've actually seen is not knowing what the culturally appropriate way is to break bad news. Like, for example, giving a cancer diagnosis to somebody who is dying. So in the United States, we always tell the patient first and not the family because of HIPAA. But in some cultures, and in many cultures that I've worked with, it's actually the opposite. You actually don't tell the patient their diagnosis, instead tell the family member first and let the family member break the news to the patient. Now, this is a challenging practice for us to do because it's different from how we've been trained, but is what is culturally appropriate in that culture we're working in. So the principles we can use to overcome this pitfall include really doing a lot of deep pre-departure training and reading about the culture and the history of the country you'll be traveling to. It's also important to learn about common diseases and also the government-sponsored protocols that are used to treat these diseases, because they're often different than the way we treat these diseases in the United States, including even just basic stuff like hypertension and diabetes. Like, you're going to have very different medications and different protocols. And lastly, it's also important to understand the roles of the upstream factors on health, including poverty, inequity, and public health infrastructure and human resources. So it's important to try to learn from your colleagues, ask these questions around public health measures and these other issues I've been talking about to see how those really do impact the lives of the patients you're going to be taking care of.
And I don't know if we have this on a different slide, but going along with what Jason is saying, I just add on humility in our own work, right? Like Jason is saying, really, if we are the ones trying to guide work in a culture that we're not familiar with or not from, that is a huge problem. And so really leading, becoming a follower of the folks who are on the ground and know the culture better than you do. Another pitfall is work that is ineffective. So work that provides temporary or short-term therapies that don't address the root causes of illness in the place where you're working. So an example of this would be a global health project that is a short-term mission to treat chronic illnesses, where providers bring a short supply of medications and set up a clinic that is not incorporated into the local health system, but instead is outside of it. And so this kind of work may provide some short-term benefits to some people who are treated in that clinic, but it can also provide or create harms. It won't provide sustainable care. It won't provide long-term care for the community. And it could actually divert resources from the local health infrastructure that otherwise could be serving the patients better. And it also could erode trust in the local healthcare system. So ways to avoid this pitfall are participating in sustainable collaborations that focus on strengthening the local capacity in both primary care or specialty care, public health, and health systems. To realize that short-term fixes to complex problems rarely actually address the underlying issues that are leading to disease for a community. Working in multidisciplinary teams, which are going to be more effective in providing sustainable solutions than purely, one provider or one group of providers on their own who are not incorporated in a team that can offer other approaches and other skills and services. And then one really important one is making sure that our programs are driven by appropriate outcome indicators. I think it's very common for programs to think, oh, we're doing great work, but not to prove it, right? And I think we all know the importance of QI work that we have in our hospitals and our clinics to make sure that we really are, having an impact, a numeric, research-based, evidence-based impact on health. And that's not always the case in global health programs. And so just making sure that we're thinking of what the appropriate indicators are, collecting that data and really looking at it to make sure that we are actually improving health as opposed to just providing services without actually improving the health of the community.
Great. Now we're going to actually talk about our very last pitfall. And that is, it's a really important one and things I don't think we think about very much, but it's about recognizing that our international travel site visits actually impose burdens on the local healthcare system. Again, I don't think this crosses our mind when we travel to another country. Oftentimes we go or we travel to another country thinking we're going to be helping, right, others, and that when we travel to another, and that our time is really invaluable. But in reality, our visits are actually resource intensive for our host site and our visits. And our visits, they also might uphold colonial structures and mentality. So when we travel, we place a burden on our host site and partners. They have to arrange transportation to pick us up at the airport. They have to provide us with lodging and food, transportation to and from the volunteer sites we're going to. They have to accommodate us. Our hosts actually have to dedicate often key personnel to help answer any questions or requests we have. The time that our host partners invest in us is time not invested in other important health programming that might be needed, such as maybe doing mobile clinics or delivering medical supplies or medications. So, and in terms of perpetuating colonial mentality, I've seen visiting healthcare workers demonstrate their implicit biases and thoughts. Like, we're going to help these folks because they can't do it from themselves, or they view themselves as saviors, right? I've seen healthcare workers justify their actions by saying that they're better educated than the local population, thereby thinking that they know what's best for the patient in a culture and in a country that they have little knowledge about. This attitude is not only racist and colonialistic, but it's severely detrimental. We come from a place of privilege and power, and we have to realize this, and we have to own it and be cognizant of it, so that when we do not perpetuate these colonialistic thinking and practices when we go abroad. This is a really important point. So the principles we can use to overcome this pitfall are being cognizant of our travels, is being really understanding and being cognizant that our travels do take up a lot of time and take up a lot of resources, right, from the sites we're working at. And that when any projects we do abroad, it should really be done abroad by the request of our host sites. We shouldn't be identifying the needs. We should be responding to needs identified by the local populations. And we also have to recognize that there will be power imbalances where we work, and that the power historically lies with us. We need to fix and correct this power imbalance. And we can begin by doing this by, as what Alexa mentioned earlier, practicing humility at the site and learning about decolonizing global health. Next slide. So this is the very last slide we have. And it's a slide that Alexa and I talked about to highlight what we think are the core elements of effective global health work, which are number one, humility, introspection, solidarity, which really means standing side by side with our local healthcare workers and local patients and local populations, and social justice, which really is working towards equal and equitable opportunities for all. If you practice global health, incorporating these core elements and virtues, we really believe you're going to have a successful trip and a wonderful experience. We recommend that you reflect on these 4 core elements and how you will employ these whenever you do global health work. And we encourage you to take that time to reflect on each of these core elements before you leave, but also especially when you're on your trip, right? And when you're on the ground working, because you're going to see these come up quite a lot. So with that, we want to thank you for allowing us again to give you this short presentation. But we think that this talk on ethics, and especially these pitfalls and things we can do to overcome these pitfalls, are really important lessons to learn if you're going to travel abroad. And I think that's really it for us. Some references, and there's a QR code if you'd like to also just give us any feedback. And I know we'll get feedback too at the end of all the sessions for this whole session, as we always try to make improvements to this academic half day. But with that, we have just a couple minutes before we're going to start our very last session of the day. But I think we can just pause for a couple minutes to see if any of you have questions or comments on what Alexa and I were talking about.
This is Annie. One thing that came up for me was I'm one of probably a lot of people who did a global health experience as a med student, like right after first year. And so I had like truly no medical skills that were usable in a global health setting. And definitely had the perspective of like, I'm going to learn more than I contribute. But ended up seeing how, the like $2,000 in airfare and like my whatever it cost for me to be there could have, employed a community health worker for a year, or like had a scholarship for some kind of a local resident or medical student, and left being like, should medical students ever do global health experience? Like, is that resource diversion really ever ethical? And I don't know if you or anyone else had thoughts on that.
I can give a response to that, Annie. Thanks for that comment. And yeah, I think we give this presentation and we're talking about the best, the ideals, but I've been there too. I was also a med student who, went and did a program that I really got a lot more than I provided. And I have similar thoughts to you. So I really appreciate that feedback. And definitely I think a lot of us have been in that position. And I think it's a really good question. And I think people would answer this different ways. I do think there are places, probably the answer to that I would say is, as a clinician, a med student probably doesn't have a role doing health programs either in the US or abroad, except with like very specific tasks that they are trained to do and very good supervision and incorporation into an organization that has a longitudinal relationship with that community. So, you know, I think about there's like a foot care clinic at Harborview where medical students rotate here in Seattle, and they have really close supervision. They do a really, narrow set of skills. And I think that's appropriate. And I think that would be appropriate in the US and abroad, working on, programmatics as opposed to clinical work might be appropriate both in the US and abroad for a medical student. But I think you're right that working as a clinician, trying to work as like an internal medicine resident is probably not appropriate for is definitely not appropriate for a medical student because they don't have that training or ability to perform clinical reasoning. I don't know, Jason, if you have other thoughts.
Yeah, I think that's a great answer. It's thanks for that question. Yeah, I think it's super complicated. It's hard to draw that line, of what's beneficial, what's not beneficial. Some medical students who go, it changes, their career path, and they really end up wanting to do global health, and they do some great work, and others do it just to travel, right? And so part of this is really looking at yourself and your deep desires and your gifts. And if your gifts and desires and values are to do global health work and to work with this type of population, then I think, if you do it, as Alexa said, with a really good group, a good community, a good mentorship, then I think that makes a lot of sense to do that. But if you're not, if you're doing it for other reasons, then no, I don't think it's the right thing. I think those resources, like you said, could be used much better ways. I will say traveling, I've been on the receiving end of this, working with Partners in Health for years, and we get so many travelers coming, and it's I've done it myself, but it's a burden hosting people. It's great. Like they really help. Like some people really help, but it's a lot of time that we have to put into doing that. And then if you're going to do that in the public sector has very few resources to host people. So you want to just make sure whatever you're doing is really needed and identified by the community and supported by the community. Go ahead.
I was just going to say, another thing to consider is, if that money were to be utilized in a different way, is utilizing that money in a way sustainable also, thinking about, are you creating an aid, like a program of scholarship and aid that is all externally funded in and of itself is also not sustainable. So it doesn't necessarily mean that utilization of the resources is necessarily better. It's different, and they all have their own pros and cons.
Yeah, that's a really excellent point.
That's a great point.
I think maybe it also depends on where these funds are coming from. Like if it's your own money that you're using to fly and you're paying for your own lodging and food, then perhaps it's just tourism where you do help a little bit and you're contributing to the economy with your funds. If it's coming out of, funding that otherwise would have gone to clinical programs, then that's a different question.
Yeah, good point. All right. Well, thanks for your questions. Great questions. Alexa, do you think you could